Everyone here? All right, well, welcome everybody to the Uveitis support group from the Ocular Immunology and Uveitis Foundation. We have turned our support group over to Zoom. And so it's really nice because we have people from all over the country able to join us now. The way that tonight's support group, the format of the support group tonight is that I will have a few announcements, and then I'm going to introduce Dr. Anesi, who will be speaking about advocating for yourself as a patient. We will have a patient speak about her experiences, and the mother of Allison Justice, who's our Director of Development. As you know, she has uveitis related to juvenile idiopathic arthritis from being a young child, and her mom is speaking from a parent's point of view. And then we're going to open it up for discussion. When we open up for discussion, you can disclose as much as you wish about yourself. It's nice to introduce yourself with your name, your diagnosis, and whatever is said here stays here. It's like Vegas. So everything should be confidential and we don't share information. Again, you can say as much as you want about yourself, and you can use first name or whatever you want to introduce yourself. Remember that you're all muted until we open it up for discussion. At that point, you can unmute yourself. I think we have the capability of doing that as well, but please stay muted until it's your turn to ask questions. When we do open it up for discussion, we are a self-help group. We don't give any medical advice unless we are educated and trained to do that. We help people by sharing our experiences, and we're helping people to move forward from this point in our disease to help us cope better and live better. Having an ocular inflammatory disease or a chronic illness in life. So with that, I'm going to share some slides. So bear with me while I open my slides up and make a couple of announcements. Okay. So we have our Walk for Vision again this year. We will be virtual again this year, which is kind of fun because you can really, as we call it, do anything for vision. You don't have to walk, you can hike, you can do yoga, you can swim, you can bike, you can do something fun with your family. And then we get together for a Zoom. It's about an hour. We have different patients speaking. We'll have different ocular inflammatory specialist speaking, and it's just a nice event, a lot of camaraderie, a good support group event. So that is June 6th, 2021 at 2:00 p.m. We'll be sending out announcements for that. You can go on our website to hit the link for Rally Bound and get started with your Do for Anything vision this year, which has been turned out to be a great fundraising event for the foundation and supporting all of our mission. Let's see. For some reason, my slides are, there we go. Okay, and then just another announcement about education. So remember, our mission is about patient education, physician education, educating the next generation of uveitis specialists, and support for patients and family members. So our Walk for Vision is a fundraiser support and our research, of course, our research, education, and support. And then we have every year a educational event for doctors, and we invite patients to join that as well. Last year we had an ocular inflammatory disease crash course, and that is still online. So if anybody is interested, that you can go on our website, uveitis.org, on the homepage. You'll find the link, and it's free, and you can review that. We have an upcoming course this year, another crash course, which you're doing as a hybrid, so part in-person, part virtual. Again, patients are invited. It's going to be at Duke Eye Center this year, where Dr. Foster and I helped to start the Stephen and Frances Foster Ocular Immunology Service there to help. We basically brought Mercy south. So we hope you all can take advantage of those free events and help to educate yourself, which again helps to advocate for yourself, as Dr. Anesi will be speaking about. And with that, I'd like to introduce Dr. Anesi. Many of you already know Dr. Anesi. He's obviously a partner and now owner with Dr. Chang of Mercy, Massachusetts Eye Research and Surgery Institution. Dr. Anesi was born in California. He was educated there at UCLA. We won't hold anything against him. He did an undergrad and graduate degree there, and then went on to study medicine at Keck School of Medicine and University of South Carolina. From there, he went on to do a surgical internship at UCLA Medicine in 2007, and then he decided to come east. He went to Nassau University in East Meadow, New York, where we trained a few fellows from their great program. And he was there, he did his ophthalmology there, and he also served as chief resident. He then came to us and came back when we were in Cambridge and started his fellowship. After his fellowship, he joined us on staff in 2011. He became a partner in 2016. And now, as I said, he is owner with Dr. Chang of Mercy. Just started January 1st, 2021. He has been a sub-investigator in many clinical research trials out of the foundation. And since his fellowship, he continues to expand. He's authored numerous book chapters. He's peer-reviewed publications in ophthalmic and rheumatologic literature. And he is the next budding Dr. Foster. So with all ado, I'm going to hand it over to Dr. Anesi.
Well, thank you, Frances, for that introduction. Anybody can hear me, hopefully. I was asked to come here and to the support group meeting tonight and speak to you all about self-advocacy. I think I'm going to try to share my screen. Got a little feedback in the background there. If there somebody that needs to be on mute, maybe. Sounds like something's going on.
Here, could everyone mute themselves? I'll try to mute everyone who's not muted.
There we go. I think that might be it. Anyway, so like Frances said, I'm originally from Los Angeles, but now I've been in Boston for about 10 plus years. University of Southern California, actually not South Carolina, but that's okay. Arch rival of my undergraduate program. So now we got something really loud in the background.
Hold on, I'm trying to mute everyone, but I don't want to mute you, Steve.
That's okay.
Okay, can everyone mute themselves if you're not muted?
I think it might be, oh, did we get it? Good.
Okay, great.
Okay, and then let me share my screen so I can get going here on my presentation. I think, are you guys seeing my slides, my screen now? Yeah.
Yes.
Okay. So again, welcome. Allison and Frances asked me to talk tonight about patients being able to advocate for themselves. And I think that that's an incredibly important topic. I run into that problem a lot with respect to patients dealing with other physicians. I think patients probably run into it with me every once in a while as well. I can't imagine any doctor hasn't gone through that problem. And it's important because the patient-doctor relationship is critical for any plan to work and go forward, at least to work well. Obviously, patient and the doctor have to trust each other. They have to mutually respect each other, and there needs to be understanding about the reasons for why you're going to go forward with the plan. And there's always a sort of an emphasis on doctors to be efficient and go quickly, but sometimes you have to take some time to explain things correctly and discuss with the patient, and the patient has to discuss with the doctor what the plan is, why they think it's going to work, and if there are other options to go forward. When it comes to treating ocular inflammation, it's particularly difficult because most ophthalmologists or eye care professionals in general have no desire, much less any real knowledge about how to treat some of the real complex things that we do see at Mercy or any other uveitis clinic. And so trying to find someone who is not only knowledgeable enough to deal with the problem, but willing to help somebody, because it takes a lot of time. It's not quick, easy work like most eye doctors have to sign up for when they first, begin their training. It takes time. It's a lot more medicine. It's a lot more of understanding the whole body and how it works together, picking up cues from non-ocular problems to help treat the eye. And when it comes to the patients coming into the exam room with the doctor who's trying to figure all this out, it can be very frustrating sometimes, especially when people don't always understand the problem the patient has, because again, these problems aren't always extremely common. And most doctors don't have formal training. I can say that in my residency program, I probably hardly had any uveitis training whatsoever. Most residency programs actually don't have a formal uveitis program or instructor or somebody who's been trained in a fellowship. So you can imagine, of the 130 or so residencies across the country, that it's going to be hard to really get people interested in the field, much less actually trained. So that's one of the big hurdles that we are trying to overcome with the foundation. But now you're the patient and you're coming into the exam room and you're trying to figure out exactly, what you're going to do when this doctor starts talking about the disease that you may have been through several doctors to get to this doctor to start speaking about. And you have a lot of questions when you come in. The doctor may sense this, and I can tell you that it's not always easy to deal with a patient who has a zillion questions about their disease in general, especially because it's hard for somebody to come in right away to a picture that the patient has been sort of painting for years. The doctor's just stepping into it for the first time, getting a fresh look at it. They don't necessarily understand the amount of grief, the amount of struggle, the amount of frustration the patient has been through. And all those questions are stemming from all that time sometimes. And it can be very hard to sort of take on all at once. So that's one of the challenges the doctor has, is to step back and understand where the patient's coming from, and not try to avoid all these feelings. It's easy to get intimidated, even angry sometimes, when patients are challenging your knowledge about something, because they're not used to hearing the types of things that you actually may be trying to tell them, or they may be really anxious about something. For example, we talk a lot about types of therapy. Chemotherapy is a big bad word that we use in our clinic on a daily basis. And I can tell you, even today, I made a person start to come to tears when I even mentioned the word. She just wasn't ready for it. And I tried to sort of break it to her very easily, as I actually had spoken to her about it a couple years ago, as a means of trying to treat a problem that was pretty severe. And I tried to make it sound as sort of unintimidating as possible, but it's not something that I can avoid, because again, patients are going to sometimes go on to online portals and read material about treating uveitis, and they're going to see things like chemotherapy. So it's my job to try to prepare them for the types of information that they're going to be getting. So patients come into the room, again, armed with questions, lots of things. The doctor has to keep some poise, be able to answer those questions as well as possible, understanding where the patient's coming from, and then try to impart some sort of confidence in the patient that the doctor really knows, where the patient's coming from and is trying their best to help, and hopefully can actually achieve, the goals that the patient's trying to meet. It's important for patients to feel comfortable asking questions, though. That's a really important thing, because knowledge the patient's having the knowledge of what's going on is important for the doctor to be able to continue treating. If a patient doesn't understand why they're doing or anything the doctor asks them to do, or there's not a lot of motivation to follow through with that. I have a lot of times, I've seen patients come from other clinics and they have a bunch of medication. They have no idea why they're on any of it. I've asked them, did the doctor explain what your condition is? No, not really. And this is coming from a person who may actually specialize in a particular problem that patient was being seen for. So it's important to be able to feel comfortable asking questions because you're there to learn as well. It helps the doctor and the patient develop the plan together. Remember, the plan affects your health. And so for you to understand what's going on and be able to ask questions if you don't understand is pretty important. And it also helps to establish that foundation of trust. So don't be afraid to ask questions if you're in a room with a doctor and something doesn't quite make sense. Maybe you weren't concentrating, maybe you were overwhelmed with the amount of information that you're getting. And that's something that I always try to do too. I try not to overwhelm with too much information. I mean, I can have a patient come in for the first time to see me who has literally 8 different problems, all of which could take a half hour to talk about. And I'll try to pick the most important things to discuss and concentrate on those, because if you get too much information, it's going to be impossible to remember all that. And I've been on the other side of that as well. Many of you know or may not know that I've had, a child that's been pretty sick in the past, and we had to undergo a lot of different types of pretty intense therapy, including a lot of the medications that some of you may have been on. And it's a lot. And if you need to ask questions about what's going on, you need to be confident enough to do that, and the doctor should make you feel comfortable enough to do that as well. So I can't stress that enough. And I don't mind when people ask me questions. I actually I'm happy to answer anything. It makes me think that the patient is engaged in what's going on. And if a patient is completely not engaged in their own health, then the doctor's not going to be a whole lot of help. I'm not going to sit there and tell you what to do, and I'm not going to go home for you and do it for you. I'm going to tell you what I recommend, based on what I know, and then patient's job to go home and follow through with it if they agree. And so again, it's why it's important for the patient to be able to understand what's going on, and again, ask questions if they need to. One important thing to know and remember is that the patient is the customer. Doctors got the setup to be able to offer advice and recommendations based on years of training, but the patients are the ones seeking care, and they're going to be able to go and find the doctor that they want. The physician, because of this, should try to help meet the goals of the patient that comes to see them for each and every visit that they have. The patient also has the right to help direct the course of therapy as offered by the physician. Obviously, that has to be something that everybody agrees on. But the patient isn't forced to do something that the doctor recommends. The doctor has, that's simply why they call recommendations. They're not called mandates. So, doctor makes some recommendations. Patient says, I think I like that. I don't think I like that. That would be an important thing to talk about with, the MD too. If you don't like something, speak up and say why, and ask whether or not that's necessary. And the doctor will give their opinion of whether or not it is. And then you can go from there. Also important, if you do agree on something, that you're going to try to do going forward, and you decide to change it, it's a good idea to reach out to the doctor and let them know that you're not going to be doing something exactly the same way, at least if it's going to be a while before you see them, because sometimes the doctor's counting on you going home and following through with a plan and coming back with the result to see how something may have worked. But anyways, it goes back to the patient being the customer. You have the right to choose the doctor that you want to see, work with that doctor, and if it doesn't work out that the doctor is meeting your goals or your needs, it's okay to fire them and seek care elsewhere. Fire is kind of a pretty aggressive word, but I mean, you're the person asking for help. You're allowed to ask it wherever you like. There's lots of reasons you might want to fire your doctor. You may not trust them anymore. You may not agree with anything that they recommend. You may not be getting out of the sessions that you have with the doctor you're not maybe not meeting any of the goals that you're trying to meet. It could be for any reason that you have. You can leave that doctor. Maybe you just don't like the way they look. Who knows? It's not a good reason to leave a doctor, but whatever. It doesn't matter. You're the person seeking care. You can go wherever you like. Doctors should not be upset. They should be completely comfortable whenever a patient asks to seek another opinion. Anyone who ever comes to me, Dr. Anesi, should you mind if I go see this doctor and see what he thinks? Or, would you care if I, just saw someone else and just see if they say the same thing or if they have another suggestion? Of course, sure. That should never be something that a doctor feels uncomfortable with you asking, or they should never feel slighted, or they should never get their feelings hurt if you're interested in asking another person about care, or even if you'd like to go somewhere else. If someone wants to do the surgery with another patient, another doctor, that's completely fine. And that just happened to me the other day. I had a patient who wanted to have surgery with another doctor. We'd had a series of surgeries that weren't as successful as we were trying to be. Glaucoma surgery can be like that sometimes, and tried a different approach. I said, that's completely fine. Another doctor and I talked about it and was very comfortable with it, and the patient's going to go ahead with the therapy that way. And that's okay. There's nothing wrong with that. Similarly, I've been the other way around. I've had a patient come to me for care when they are normally seeing another doctor for types of surgery and care that they would normally see them for, but because of trust or because of a relationship that I've developed with that particular patient, they came to me for the care, and then afterwards, went back to the other doctor for the aftercare. Now, I don't know how many of you know Sue Paulson. She's a patient of ours at Mercy. She's been with us a long time. I've known her for almost my entire tenure at Mercy, or maybe the entire 10, 11 years I've been there. She's one of those patients. She came to me recently for advice and care, and I helped her. And she, I think, is going to talk a little bit about her story and what happened with that interaction between me and another doctor of hers. So I don't know, Allison, if you'd like to turn it to Sue for a minute.
I'm unmuted, I guess.
Oh, there you are.
Yeah, hi. Do you want me to just talk?
Let me unshare my screen for a second. There you are, Sue. I think that.
Okay. Hi, everyone. I have been a patient of Steve's for, probably over as long as you've been there. You were the fellow who I saw when I first went to Dr. Foster's. I'm in a good place right now, actually, because I had primary intraocular lymphoma, but I'm in remission. But I am left with a lot of, side effects. So one of the side effects right now is I'm dealing with glaucoma. And so, we've tried drops and we've tried other therapies, but right now surgery was the only option. My kind of predicament is that we live in Illinois and half the year, and we live in Florida half the year. So I juggle 2 glaucoma doctors, and that's tricky enough because, they don't both like to take on your case fully. So you're sort of relying on both of them. Recently, I needed a surgery, and I really just was not sure which doctor to choose because I don't know them very well. I've only known them for probably 2 years each. And so I reached out to Steve and Dr. Anesi, and he said he would do my surgery. And it really comes down to who I felt the most comfortable and confident with. It's scary for me to go through surgeries again. I'm kind of in a good place right now, and for both my eyes to be operated on and heal, and to be sure if there was a complication, I could fall back on that doctor and really know he would be there for me and do everything to fix the problem if there was a complication. So I had Steve do the surgery, and I went back to Florida, to Sarasota, to the eye doctor. and I was not received very well. He pretty much said, why would you go to Boston for your surgery? And I tried to explain to him, you know, that I had this relationship with Steve and I just trusted him after other surgeries and things I'd been through. And then I've been seeing him, I did the maintenance with him, but every time I go there, he has sort of a comment. And so after talking to Steve, I'm going to get the other eye done next month. I think after that, I will seek a different doctor who maybe has more compassion and understanding and would help me juggle my situation, where I would like to live half the year in Illinois and then half the year in Florida. But it just comes down to, I think, don't just, you don't have to stick with that doctor. Like Steve said, if you feel uncomfortable or just not happy, I'm going to be seeing this doctor probably forever, because when you have glaucoma, you have to be monitored forever. So I feel like there's a point where I would like to work with somebody who I'm comfortable with. So that's just sort of my little story, but I'm sure others have had similar instances.
Thank you, Sue. We appreciate that input. And I think it is difficult. I know, like, Steve can speak to that, and patients of Dr. Foster's who come from other doctors, and you get consult and recommendations, and then the doctors at home don't want to follow the same advice. So it's very frustrating, but those are signs that it's time to move along.
Yeah.
So I had one more slide to go on after that, if you want me to go back to it for a second.
Sure.
Let me just share one more time. Hold on. And I think it's an important slide for everyone to realize. If I can find. There we go. My last point, doctor may not always know what's the answer to the problem or to the question that you may have. And this is important to realize, because doctors are human. They don't know everything. If you had any idea how much information there is, even in each sort of subspecialty of each field, it's overwhelmingly just ridiculous how much information there is out there. It's really hard to know everything about everything. But we try our best to know as much as we can about what we're treating, because that's what we are asked to do. It's important to realize when the doctor may not know the particular answer that you're looking for, so you don't feel like there's something that they're trying to keep from you, because, it's not my goal to try to hide something from anybody. If something is asked of me that I really don't know, I'll let somebody know. I say, that's not something that I'm familiar with, but I'm very interested in figuring it out, and I'll be able to get back to you about it if I need to. Not every question has an answer. I've been asked many questions in the past where I basically said there's no answer to that. We have no idea, nobody knows, or it's impossible to predict the future. Somebody wants to know exactly what's going to happen with this situation or that situation, and then the old question that doctors get asked a lot, what are the chances that this will happen? What are the percentages that this will happen? There's lots of studies and lots of reports about different conditions and different situations that tell you what is more or less likely to happen, but you have to remember that you could be on either side of those percentages. So you may not fall in the 99% of something that is almost sure to happen. You may fall in that 1% where something doesn't go the way that you planned. And so to be prepared for it, you have to know what each side is. And the doctor may tell you that something is more or less likely to happen, but not to get too locked up into absolutes about anything that happens. And just work with the doctor to try to go forward and make the best plan possible. So with that, that's what I had to share tonight. And I look forward to a little bit more discussion, I think, from Francis. So I'll stop sharing my screen now.
Thank you, Stephen. I think that's a good introduction to Allison's mom, Linda. And I see her on here. You want to unmute your mother? Because she, I think, has a nice story to share about her experience as a parent advocating for her child. And I think that also relates to Steve's slide about, physicians and physicians not knowing everything. And how to move on from a physician that you feel like a connection to, but you realize they're not doing the best for you. So with that, I'll introduce Allison's mom, Linda. There you are. Allison, unmute your mother.
Okay,
Okay, there you are.
great.
Welcome. Thank you for joining us tonight. We
Hi.
appreciate it.
Hi, everyone. I'm Linda Justice, Allie's mother. And Allie was diagnosed with uveitis when she was about 5. And we went to a pediatric ophthalmologist who really didn't know that much about uveitis. And then we went to a very well-educated, fine ophthalmologist in Manhattan who Allie worked with for probably 15 years. And he then died, and there was an ophthalmologist in his practice who Allie really liked. He was young and she could relate to him, but I felt he wasn't experienced enough. So she was in his office one day with her dad, and they were going to do a procedure. And I asked him how many of these procedures he had done, and he hadn't done that many. So I asked Allie to leave his office, and I explained to him that I didn't feel comfortable with him doing this procedure. And Allie was furious with me. Actually, she was even more than furious with me, but I knew that she did not belong in that office. And we found another ophthalmologist who was more experienced than the office she had left, and things turned out better. But you need to be your own and for sure your child's advocate. And that's the path. If you think something is not right, then you need to take hold of it and do what is right. Somebody could be really nice, but they might not be the best person for your child or for yourself. And that's my story.
Well, thank you, Linda. We appreciate that. And I know, I mean, I have a similar story with my mom too, and being taken to people who said they were experts and weren't experts, and sort of advocating till we got to the right person. So I think that's important for all of us, whether it's a parent or yourself, to know, like, follow your gut, as Linda said. If it doesn't feel right, move along. So I'd like to open up the discussion now. Others can talk about their experiences or maybe struggles that they're having. You can also open it up to questions that you might be having about your care or looking for a specialist, etc. So we have about a half an hour left. And so anybody who wants to speak, just unmute yourself. And if you're having trouble with that, you can raise your hand and we can help you with that. There's also some stuff in the chat.
Yes.
Yeah. Maybe I should address the first one. Well, let me address, whoa, something just came through. Real quick about COVID, because there's a lot of people I think that are interested in information about that with respect to what we're doing. I think we have information on the website about it, but what we're telling people is that if you have the chance to get the vaccine, you should go ahead and do it. None of the vaccines that I know of are what they call attenuated or live vaccines. They're all dead. I think that's right, Francis, right? Johnson & Johnson is also dead. At least Pfizer and Moderna are. So go ahead and get them. There's a difference. There's a lot of difference of opinion on what to do with your medications when you're getting vaccinated. You could probably safely just continue them. Some people have said to skip the dose of medication that you may be on that suppresses the immune system right around the time of the vaccine. Some haven't. There's no right answer. I think that you're probably going to be pretty likely to develop antibodies no matter what you do. So I hope that answers the question with respect to that, because that's probably something everybody can relate to. So.
And there's another one, Dr. Anesi, a mother of a child who's 10, diagnosed with uveitis at age 6. Did you see that?
I did, yeah. I was just going to review that. So that for that person, I think it's important to remember that it can sometimes take several attempts to find out what's going to work for a particular type of uveitis. Pediatric uveitis can be particularly stubborn and very hard to treat sometimes. And I can attest to that in some of the patients I've tried to help, being very, very difficult to manage as far as getting their inflammation under control, even if they'd done everything in their power to try to help me go forward with things. So important to remember the goal, do anything it takes to get things under control. Steroid free is always the goal as well, and controlling all the other things. I can see that she's on some glaucoma medications also. That's very important to remember. All of those problems need to be put together in one big picture by the doctor or doctors that she's seeing. And if there are more than one doctor, you have to make sure that they're talking. But I would just really say keep going until you find something that works. You're always welcome to come see us at Mercy too, if you're able to come, if you need another a pair of eyes on your child as well. So remember that as also.
And I think that would apply for Alyssa's question, who's at UCLA. I think something we didn't really talk about, but we've learned over time by having support group and having online support groups, is that a lot of uveitis specialists walk the walk, but don't, talk the talk, but don't walk the walk. So, and everybody has a different philosophy of care. They don't always follow along the step-ladder approach. They may not be as aggressive. They may not be as experienced with all the medications that can treat uveitis. So that's where I think like Mercy is very unique in that I'm not pumping Mercy. I'm just saying Mercy, Dr. Foster, all the doctors he's educated. We're very unique in that we have a wide spectrum of treatment for ocular inflammatory disease. So sometimes, even though you have a uveitis specialist, it might be a good idea if you feel like things aren't going your way, you're not getting your answers, to get another opinion from another uveitis specialist. And it just so happens in the COVID time, you can do that through telehealth medicine. So I think, Alyssa, it sounds like your situation is very complex, not something we can answer in a support group. But I would advocate you for reaching out, maybe in an email. Maybe you can email Allison. She can get you connected with Dr. Anesi, and perhaps you could have a telehealth consult, or we could answer some of your questions via email. And the last item on chat is the COVID vaccine and flare-ups. I think Dr. Anesi can speak to this. I know that it's so new. We don't have much information. We've had a few patients that maybe show signs of a flare-up after the vaccine, but it's hard to know if that's a true correlation. Maybe Dr. Anesi can speak to that a little bit.
The COVID cause a flare in someone. So I actually have seen that. Any vaccination, anything that challenges the immune system to work harder than it normally does, can potentially flare an autoimmune disease or inflammatory disease. So yes, I've seen several patients where I've suspected the vaccination has caused a flare in their uveitis. My personal feeling is that the threshold for their disease to flare is probably a lot lower than other patients, because there's several people who do get the vaccine and don't flare. It's really hard to know how well something's controlled if it's quiet. Is it barely controlled? Is it way over the top controlled? Because you can overtreat something and it'll look exactly like something that's barely being treated if both patients have quiet disease. But I think you find out when situations like that occur because of the heightened immunologic challenge to the body, and then you have a flare of uveitis. And I think that that's what happens. You know, patients just have a situation, and that may be a signal to maybe increase the therapy a little bit more, so that times of stress or vaccinations or things like that don't necessarily cause a problem. It's just something that I've thought of, but it certainly is something that I've seen happen. So
Yeah, and then another text from the chat is somebody who said that they've never heard of an alternative to steroid drops. And they've been on drops for over 10 years, and it seems like they're getting resistant. So there is a whole stepladder approach to care. I can have Dr. Anesi give a brief overview of that stepladder to care. And I think on our website, we have a brochure for patients to educate them on that. It's called our Ocular Immunology Disease Brochure. And you can find that on our website. You can download it there. You can buy it on Amazon. It's just about like $1.99 or something on Amazon. But maybe Dr. Anesi can give just a brief overview of the stepladder approach to care and when it's time to move along from steroid drops.
Thanks, Francis. The idea behind the stepladder, which was pretty much coined, I think, by Dr. Foster, is the idea of something that escalates as needed. So you are going to try to start treating something with the most appropriate but least aggressive medication needed and go up from there. And the whole goal of all of our therapy is to try to avoid steroids. So I'd say that if you've never been told of any other alternative except for drops, and you have enough flare-ups to be flaring at least once a year or more, then you probably need to find another person who's actually a little bit more familiar with this approach. But going in sort of increasing aggressiveness of medications is what we usually try to do. Sometimes you have to skip steps too, because it may not be something the person can take. It may be contraindicated. It may not be a good way to treat the particular problem that they have. But things like even high-dose ibuprofen, non-steroidal anti-inflammatory drugs, or NSAIDs, if you're not familiar with that term, are entry-level medications for some types of ocular inflammation. Moving up from there, you usually go to the sort of very standard chemo drugs that we use. And chemo, I think above, there was a question about that. Chemo is just a word that describes how a medication works. It doesn't mean that you have cancer. It doesn't mean your hair is going to fall out. It doesn't mean you're going to have any side effects whatsoever. It's a medication which is a very non-specific way of treating cells that divide rapidly in the body. And that includes inflammatory cells. So by giving somebody some type of chemotherapy in low doses versus high doses that you do for cancer, low doses of chemotherapy can help the immune system from becoming not quite so overactive, and control some of the overactive autoimmune problems. So that's the next sort of step we usually take. And then of course there are biologic medications which are newer. Last 10-15 years or so, those have come on the market and been incredibly helpful in treating. And above that, it can get a little bit more advanced as well. Most people don't go much beyond biologics, but there are other medications and there are other classes, and there are individual medications that don't really have a class. They're in the class of their own. And the nice thing is that when you have multiple things to use, you can combine them oftentimes. If side effects and blood work and everything allows, that can be a way to actually very nicely combine medications and decrease side effect profiles, things like that. So the stepladder approach, like Francis was saying, is just a way to approach treating a problem with the most appropriate but least aggressive means possible, and doing it successfully with hopefully.
We have 2 more people on the chat, but I just want to see if anybody wants to speak outside the chat, and if not, I'll address the next 2 chat questions. Well, I guess everybody's shy tonight.
Well, let
So-
me, I guess I can address one thing and two things that I just saw here. Humira is a biologic, it's not a chemo drug. Methotrexate, Cept, things like that are chemo drugs. There are other types of chemo drugs too that we can use. With respect to another question I think Alyssa had that also Sharon here has, idiopathic inflammation just means that there's not really a known reason for why that particular type of inflammation exists. And that's probably about 1/3 of the cases of uveitis that we see, and even other types of inflammation like scleritis, you know, maybe even up to half the time, there's not a really good reason for it. We don't find an associated underlying systemic condition. There's not an infectious cause. There's nothing we can really find that is causing it. It's just a disease. And so we treat it. And so that's not uncommon at all. And don't feel like the doctor hasn't necessarily tried their best to try to figure out what's going on, because it may not be, there may not be an answer to that particular question. So.
And then we had the one person with the hydrocortisone. They were wondering if 10 milligrams of hydrocortisone was a problem or something that could be tolerable. Did it cause glaucoma or cataract?
Hydrocortisone, I've not actually used that very often, and I don't know how much that is an equivalent to something that is more common like prednisone.
Let me Google that.
But I will say that any steroid is potential to cause cataracts and raise eye pressure. There's no steroid that is free of that particular risk. So if somebody told you that, that's not true. There's no such thing as low-dose prednisone at all. There is only different levels of prednisone. Even low-dose prednisone can lead to problems. Now, we always try to get people off of all steroids. It doesn't happen 100% of the time. I'd say very few people just can't seem to get off any type of steroid, but depending on the risk of coming off of the steroid, sometimes it is actually needed. So, and there are people who actually depend on steroids. There are people who don't make enough steroid and they have to have steroid supplement, but so it kind of varies, but that's a different type of situation. So I hope that answers that question. Cept for idiopathic uveitis, that definitely is something that is an option that we choose from, Sam. Steroid drops should not be something that you rely on for more than just acute bouts of inflammation. And if they're being used for longer periods of time than that, then it really should be something that you go seek something else for, some other type of therapy for. Cept would be a good start. But ideally, it should have been something, hopefully, that would have been recommended a long time before 10 months goes by, at least in my view.
Okay, we have a little more time if anyone else has anything they want to add or talk about.
I was wondering if I could ask a question just verbally.
Sure.
Yeah, thanks. So I'm the one that with the hydrocortisone, I've been on, chronic anterior uveitis for many years with ankylosing spondylitis, HLA-B27 positive. And it was actually a functional medicine doctor that said, I wonder if your adrenals are kind of not kicking out enough. And I do have an appointment, by the way, with an endocrinologist just to confirm all this in a month. But I thought I'd ask you, because I mentioned it to my ophthalmologist and he said he's not familiar with, Cept or hydrocortisone. All his patients, if they're on cortisone, they're on prednisone, which of course causes cataracts and glaucoma. But people that aren't making enough, cortisone in their body, like people with Addison's disease, do go on replacement hormone, hydrocortisone or Cept, which is completely different than prednisone because it's what your body's naturally making. And so my question is, have you ever had anybody with Addison's disease who might have been on that particular maybe hormone replacement rather than prednisone, which is known for, because people with Addison's disease, you don't hear about them ending up with glaucoma and cataracts and all that. I would think an ophthalmologist would see that complication. So I just, I'm feeling great on it for the first time in many, many years. And it's, the body makes, I think, up to like, normally maybe 40 milligrams of hydrocortisone. So 10 milligrams is really a small amount. It's not going to suppress the adrenals like, something like prednisone would. So that's my question. Do you see that in people maybe with Addison's, or because it does seem like it's more of a bioidentical rather than a pharmaceutical, even though it is, coming from them.
So this is a good question. I would say that the body needs a certain amount of what we call corticosteroid to function normally. If you have not enough, like in a case like Addison's, you're going to need to have supplement. Interestingly, my wife actually had a condition like that where her adrenal glands at one point in her life didn't produce enough cortisol, and she needed a supplemental steroid. She ended up on dexamethasone at the time, and since it's kind of corrected itself after we had some of our kids. But it is a level that, if you can imagine, there's a certain threshold, high and low, where you're supposed to be in between, the amount of that type of steroid that is in your body helping it to function. If it's too low, there's a problem. Now, if it's too high, there's also a problem. If you overtreat a person who has under production of cortisol, and I don't think it really matters if it's hydrocortisone or if it's prednisone or dexamethasone, in my opinion. I think if it gets too high, you're going to be potentially subject to some of the same side effects that those types of steroids can cause. So if you have an undertreatment by your body and you're supplementing to get to the normal range, then you might actually feel real good, and that may be what you need. But if you're in a situation where you produce a normal amount and you're taking it to suppress the immune system or an inflammatory problem, and then you're at a higher level than you should be, that's where you can start to get into trouble with side effects.
So possibly taking the amount that your body actually normally would make, just sort of topping it off to where you should be, might not create the ocular issue side effects then.
Potentially, but I think that most people do create a normal amount. It's not, I don't think it's super common to have a low amount of that.
Okay. Yeah, I think I just had pooped out adrenals. The functional medicine doctor told me to try it, just a test for 3 to 6 months, see how I do. And if I'm doing great, then to start tapering it down. And I'm in like 5 months into it. I thought I'd talk with the endocrinologist, since they treat things like that more. But so I haven't started tapering at all, but I can just tell you, if it's a matter of that or being on the eye drops, this is just amazing to me. So anyway, I just thought I'd get your opinion. Thank you.
Oh, absolutely.
Okay, anyone else want to,
Dan has his hand up.
Dan?
Yep.
Okay.
Yep. Thank you for organizing this. It's always great. Thank you, Dr. Anesi, for presenting to us. I even walked away from the Yankee game when there were bases loaded and no outs against the
Whoa.
be on time on this. So just a quick story for everyone. I know that we're short on time. So I also had problems with my eyes. I did have what was diagnosed as uveitis. I went to some other doctors in Boston. They were treating me with steroids, and my eyes reacted well to the steroids. But as Dr. Anesi just mentioned a few minutes ago, it's not really intended as a long-term treatment. So I was really stuck in this cycle of on and off steroids. And finally, the doctor said, oh, well, there's this place in what was then Cambridge, Mercy, they're close, so you may as well try them out. I got to tell you, for the people listening here, the fellow, before I even saw Dr. Foster, he figured it out in like 15 minutes. And by the time Dr. Foster walked in, I was already on a course of treatment that led to maybe 2 years of azathioprine. And I've basically been off of that and flare-up free for a couple years. So I just wanted people to know that if you're not getting the care you need, definitely think about coming to Waltham, Massachusetts to see the folks at Mercy. So I feel like I'm able to give a plug for Mercy.
Appreciate it, Dan. Thanks for that.
Yeah, thank you. I think that just speaks to like our philosophy of care and using the stepladder approach to care, and you know what Dr. Foster has trained all his other fellows who have studied under him, and their philosophy of care is never give up and do whatever it takes. Those are his two mottos. And I think, you know, like we've seen with all the questions, there's no one case, unfortunately, in uveitis or ocular inflammatory disease that's the same. Or, I mean, we can't say, oh yeah, Humira works great for everybody. We just put everyone on that. It is very individualistic and it's a trial and error. So you just want to be with someone who's willing to say, hey, it's time to quit and move along to the next one.
There's some more questions in the chat.
Yeah, male, female, I don't think that it probably makes too much difference as far as how uveitis affects somebody. I'd say different types of uveitis can be found more frequently in either men or women. So it just kind of depends. Everybody's treated individually based on what they come in and it'll look like. I've seen all manners of inflammation in just about everyone. So that's sort of the way I approach it. As far as makeup or facial products being factors, no, I don't really think that I've ever seen that really be a problem. Things like tattoos or medications that you take might be something that can affect inflammation. Some diets are anti or pro-inflammatory, so those are things that might be problems. But makeup or facial product soaps, I've never seen that be a problem. And uveitis has been around for a long time, and I can't recall the exact. Dr. Foster's really good with history and knowing all the you know, the people from 100, 200 years ago that have had uveitis, or what it's been called over the years. I think it's been around as a diagnosis for centuries, to be honest. But the term itself has probably only been around for, I think, maybe 100 or 200 years, I think specifically. And then the other question about doctors being able to help somebody if they have a flare or if they don't have a flare. I've had plenty of patients come to me as a consult. It's impossible sometimes to time your flare for when you're going to see the new doctor. Ideally, it's nice to see somebody when their raging, you know, inflammation is out of control, so that you know what you're up against. But sometimes everything's completely normal and you go by history. I like to ask, and I tell all the fellows this, I said, make sure you understand exactly what the patient has as symptoms, because that will help you to understand most of the time what their problem actually is. So that's just an important thing. So it may be that you don't have a flare, but you can still go see the other doctor and see if there's anything that they can do to help your situation, even just by, you know, taking a look. And yeah, feel free to email me if you guys want. I think my email's on the website. Pretty sure about that. If not, it's pretty easy. It's just snec@mercy.com. Happy to answer any questions that you guys have if you reach out.
And Allison, I think that there's a question for you. Somebody tried to get on the link for the crash course. It looks like they wanted a guest password.
Well, I can email it to them.
Okay, so
Okay.
if
Tell
anybody
them to
wants,
email me, and then I will get it to them.
email Allison. Her email is on the website, but it's ajustice.
.org.
Say it again, Allison.
OIUF.org.
ajustice@oiuf.org. So I think we're just about at our 8:30 time. Is there anyone else who has one quick question? If not, I want to thank everybody for joining in tonight. It's great to have everybody from all over the country and the world. We can actually have an international meeting if people are willing to stay up with time changes. But it was a great talk. Thank you, Dr. Anesi. Thank you, Sue. Thank you, Linda. Thank you, Allison, and everybody else who's here tonight participating and sharing the support. And we'll see you at our next meeting, and we hope for flare-free months to come.
Yes.
Thanks, Francis.
Thank you.
And
Bye,
thank you,
everyone.
Dr.
Have a
Anesi.
good evening, and thank you guys for having me. Bye-bye, guys.
Take care.
Bye.
Bye.